Since in 1980, the HER2 was recognized as an oncogenic driver of the breast cancer. Firstly, the transmab taxane was the benefit was demonstrated in 1998. It was so transmab taxane combination was approved firstly in 1998 by Sleman Group. Then a pertuzumab combination in 2012, and the TDM trial was approved in 2013. TDX was approved in 2019, and margetuximab was also recently approved. Tucatinib, transmab triplet, and neratinib also approved in metastatic setting. In below the screen, in 2006, as with the transmab was approved, firstly in lymph node positive patients, and 2013, new as the pertuzumab, and extended as when the neratinib was approved in 2007. And also, according to Catherine trial, as when the TDM1 also are now available in since 2019. So we have many rich armamentarium in the management of HER2 breast cancer. As you already heard, that there are 4 anti-HER2 is available in the world. So extracellular domain, looking at the extracellular domain, there are 4 subdomains. So transmab is binding to subdomain of 4, and pertuzumab binding to subdomain 2. So already, previous speaker, Dr. Meehan, already mentioned that the dual vertical inhibition increases the efficacy. TDM1 is the backbone is transmab, so the binding site is same with the Herceptin, binding to subdomain 4. And lapatinib is binding to intracellular domain. So we have many armamentarium. That armamentarium classified into 3 classes. So HER2 targeted monoclonal antibody, margetuximab, transmab, pertuzumab. HER2 targeted ADC. First one is the TDM1. Now TDX is also showed promising efficacy. HER2 targeted TKIs, tucatinib, lapatinib, neratinib. So current HER2 positive metastatic breast cancer treatment landscape. So these are the landmark clinical trial done in the first line Cleopatra trial, a second line Emilia trial, and second and beyond is a TRESA study. So you need to pay attention to the PFS benefit and overall survival benefit. So with effective drug, in the previous stem, HER2 subtype was considered the worst subtype, but with a more effective drug, even in the late line, the patients get the benefit in terms of PFS and or over survival benefit. And recently, in 2020, Cleopatra end of study results was reported. So median follow-up of almost 100 months showed that if the patients are treated dual vertical inhibition, pertuzumab or hertuzumab taxane, 8 years over survival, 37%. It is quite remarkable. The safety profile is no additional toxicity. So we need to recognize the benefit of anti-HER2 blockade in first, second line, and later line. I'd like to illustrate the Miriam trial, which tested the TDM1 in first line setting compared with the transmab and taxane and transmab pertuzumab. In previous study, that TDM1 combination was showed somewhat promising result as compared with the transplant. So they launched or conducted phase 3 trial, 3-arm study, HER2 positive metastatic breast cancer, no prior chemotherapy, patients who recurred just after the completion of 6 months. So Cleopatra trial, the patients are enrolled the participant Cleopatra trial just after 12 months after the new or adjuvant treatment. But efficacy-wise, is more or less 3 arm are similar. But you remember that the Cleopatra PFS is 18 months. So TDM1 alone is 14 months. So TDM1 could be used in first line who are recurred early or who are unfit for the chemotherapy combining regimen. And what is the TDM1? TDM1 is composed of 3 complex. So the backbone is a Herceptin, and the DM1 is a payload, and it is linked with the thioethyl linker. So the ADC, antibody drug conjugate, is a basic concept is intracellular selective drug delivery to the target. So DM1 is selectively targeted HER2 overexpressing cell. The linker is minimize release DM1, which result in systemic toxicity. 1 antibody, 3 payload is binding. So drug to antibody ratio in TDM1 is known to be 3.3 to 3.6. So the mechanism of action of a TDM1 could be explained like this follows. The TDM1 binds to the HER2 receptor. TDM1 and HER2 receptor complex internalized. Then the toxin payload is degraded and binding to a microtubule. So it inhibits cell death. But because of the HER2 nature of the Herceptin, TDM1 has the advantage of ADCC. So the TDM1 has a dual mechanism of action. Several guidelines already stressed out that TDM1 for HER2 positive recurrent metastatic setting. TDM1 could be should be used in second line setting, and also can be used in second line or later line setting if the patient does not receive the TDM1 before. So efficacy of TDM1. As you already heard that the Emilia trial, the Emilia trial is the HER2 positive patients who received the prior taxane and Herceptin, and also received the adjuvant therapy but recurred within 6 months of early recurrence. In that case, the patients are randomized into either TDM1 or lapatinib and capecitabine. A primary endpoint is a progression of free survival and overall survival and safety. 2 patients' characteristic demographic data according to age, performance status, hormone receptor status, prior systemic therapy. They are well balanced between 2 arms. Please note that almost half of the patients hormone receptor positive. Mostly second line, but patients who already also more than 2 patients also participate in this trial. The efficacy data show that median PFS is 9.6 months versus 6.4 months. Hazard ratio is 0.65. So after 3 months, the PFS curve is separate and maintained, diverged and maintained with when TDM1 is added as compared with the lapatinib and capecitabine arm. And when the first reported median follow-up was 30 months, the overall survival was 30 months, 25 months. The PFS hazard ratio 0.68, but at that time, the p-value does not across the predefined p-value, but final analysis, the median follow-up 41 months. At the time, the p-value meet the predefined the hazard ratio and p-value. So 29 months versus 24 months. The overall survival, statistical overall survival benefit was demonstrated in Emilia trial. Looking at the adverse event, so grade 3 single arm TDM1 versus 2 combination capecitabine and lapatinib. The grade 3 toxicity is greater than in capecitabine and lapatinib arm. AE leading to discontinuation is higher in capecitabine lapatinib arm. Looking at the adverse, if the profile, diarrhea, hand-foot syndrome is higher in capecitabine, lapatinib arm, and the AST, ALT, thrombocytopenia is higher in TDM1. But overall, grade 3 toxicity is definitely higher in capecitabine and lapatinib arm. So Emilia trials demonstrate that higher efficacy, less toxicity in second-line setting when TDM1 was used. Teresa study, which I also participated in as a string committee members, the patients who received the second or more prior HER2-directed therapies and patients who received prior treatment transfer lapatinib and taxane. Then patients are randomized into TDM1 or TPC arm, chemotherapy or anti-HER2 blockade or endocrine therapy. So the primary endpoint is PFS and overall survival. Here also study showed also demonstrated that the improved positive in terms of PFS, 6.2 months, 30.3 months. The hazard ratio is 3.5, and the overall survival final analysis showed that the overall survival benefit was also demonstrated. When the HER2 blockade is introduced in the management of the HER2 positive breast cancer, physicians are curious who got the most benefit, who also treated with less toxic regimen. So the mRNA, in Teresa study, the mRNA, regardless of mRNA status, the benefit was shown in TDM1, but TDM patients with higher HER2 mRNA showed better PFS. But PIK3 situation is known to be resistant to HER2 blockade. But when we treated the patients with TDM1, the efficacy does not depend on the PIK3CA. So regardless of PIK3CA, the patients with the mutated PIK3 wild type, the benefit was demonstrated if the patients receive TDM1. Camellia study is this kind of a real-world study. So after the phase 3 is demonstrated, pharmacy would like to get more safety data. So this is a so-called phase 3B study. So after the phase 3 study, single arm study to get the more this data of the data of the safety, and also see that the efficacy is well maintained in large cohort. So Camellia study is a phase 3B study, which is the largest one. 2,000 patients are enrolled, HER2 positive, treated with TDM1. PFS is also 6.9 months, and the median overall survival is just 27 months, more or less comparable to Emilia data. So when we treated the patients, the CNS metastasis is a problem. So Teresa study, 11% patients have already CNS metastasis. Emilia study, 9.6%. Camellia study, 19% patients CNS metastasis are enrolled in the study. So patients with CNS metastasis, in terms of PFS and overall survival, 5.8 months versus 17.3 months. Overall survival in Emilia study with the CNS metastasis is 26 months. In Camellia study, overall survival, median PFS is 5.5 months and 18 months overall survival. Response is 20%. So when we see the efficacy, the response rate is more or less similar, regardless of whether patients who receive the radiation therapy or not. So CNS metastasis is a problem, especially when we treated the patients in later lines setting. But with the TDM1, the efficacy parameters show that more or less similar without CNS metastasis. In early 2000, I also had the young patients who recurred 2 or 3 years later. But when we treated the Herceptin and Taxane, but the disease progressed like this in CNS, so-called miliary metastasis. So we treated the patients with the radiotherapy, but some tumors regress, but some areas are also increasing during the whole brain radiotherapy. But what I'd like to say today is that CNS metastasis is a very prognostic feature, but please don't give up, because after the radiotherapy, other HER2 treatment, she lived more than 10 years. And a tolerability issue. So based on the pooled data, Emilia, other phases, almost 7 clinical trial pooled data, the fatigue is the most common adverse AE when we treated the TDM1, fatigue, nausea, thrombocytopenia. But of note, the grade 3/4 toxicity is very rare. The thrombocytopenia grade 3, very rare. Especially interesting toxicity is that thrombocytopenia, hepatotoxicity, LV ejection fraction. But grade 3 or 4 thrombocytopenia is reported during the first 2 cycles of TDM1. It is periodic, but mostly it will be with a dose reduction, we can continue the treatment. Hepatotoxicity, hypobilinemia more common than lapatinib and capecitabine. LV ejection can be occurred, but is rare. So starting with the recommended dose is 3.6, but first dose reduction is 3.0 milligram per kg, and second dose reduction is 2.4 milligram per kg. So when we face the grade 3 thrombocytopenia, hold and restart at the same dose, and then when place recovered up to 75,000. And the serum transmission transaminase grade 2, we can treated at the same dose. And the bilirubin and elevation, we need to grade the toxicity, and we adjust the dose, and we can continue with this dose modification. And the PRO. So Emilia, the PRO data of the Emilia data, post-treatment 6 week, 12 week, 18 week, post-treatment period, TDM1 is better than the lapatinib, capecitabine, except drug continuation at 12 months. But overall, the improvement of well-being score was favored in TDM1. So 55% of patients in the TDM1 had a clinically significant improvement in symptoms from baseline, compared with 49% of patients in lapatinib capecitabine arm. And also, when we see the PRO's Teresa study, a global health status significantly better in TDM1. And also fatigue, when we treat the patient, the fatigue pain could be an issue, but those AER could be manageable, tolerable, compared to other regimen, TPC regimen. PRO of the Emilia and Teresa showed a better PRO as compared to a control arm. So, as the ASMO guidelines suggest, made the magnitude of clinical benefit scale, MCBS. So those are, so when new data is coming, overall survival data, quality of life, and hazard ratio, prognosis of the condition are taken together. So then score is made. So a primary endpoint, when overall survival is a primary endpoint, in standard arm can be classified less than 1 year, 2 years, more than 2 years, and PFS benefit is standard arm less than 6 months and 6 months. So when a new treatment is compared with overall survival and PFS in a metastatic setting, it can be graded like this. So Emilia trial hazard ratio is 0.6, so it can be classified into grade 3. If the new data demonstrate the QOL benefit and the grade 3 toxicity less, it can get a grade 1 additional benefit. So when the new regimen, according to MCBS scale, graded 4 and 5 is substantial, considered as a substantial benefit. TDM1 Emilia trial, efficacy-wise rated as 3, but QL data showed the benefit, so it can be Emilia data considered as MCBS grade 4, scale 4. So it means that TDM1 showed a substantial benefit in the management of HER2 breast cancer. I'd like to share my case. 44-year-old patients, BRCA was negative. So patients was presented de novo stage 4 in the HER2 positive, ER positive. But patients with treated with the Cleopatra regimen. So this is already gone away. But 1 year of treatment, brain metastasis occurred. But extracellular was no evidence of disease. So patients are treated with 4 times of gamma knife. So this is all controlled. But patients progressed in liver, so we switched the systemic therapy into TDM1. after 3 cycles of TDM1, the liver mets was dramatically improved. Although we experienced some plate thrombocytopenia, but with the dose modification, the patient is stable more than 10 years, and also CNS progression was not noted with the TDM1 only. Case 2, the patients, the 47-year-old man, old woman, received at the time she refused the hair loss chemotherapy, so she just received endocrine therapy. But 4 years later, patients recorded with multiple metastases. At the time, Emilian study was available, so patients participated in TDM1 first line treatment. So she's more than stable, more than 10 years. She visited last week. When she recorded liver metastasis was multiple liver metastasis was noted, and 3 cycles of chemo, the liver metastasis disappeared. Clinical CRs are maintained up to more than 10 years. Although she experienced thrombocytopenia in the beginning, AST, ALT elevation, mild elevation was noted, but she's quite stable up to more than 10 years with the TDM1 alone. Evolving treatment paradigm landscape. So you already heard that neratinib and tucatinib was very effective in the CNS metastasis, and that TDM deruxtecan also showed promising efficacy, especially in previously heavily treated patients. Yeah, the basic mechanism of ADC target the HER2, and the internalized receptor is recycled, and the complex is degraded into payload is released, and it causes cell death selectively. This kind of TD1 is the first one. So after TD1, many ADCs actively under investigation now. So in second line setting, KT3, TDM1 plus minus atezolizumab is actively under investigation in PD-L1 positive. Destiny already accrued the TDXD versus the TDM1 already accrued the enrollment. It will be presented this coming ESMO. EPIC trial alpelisib, HER2 climbing. This trial is ongoing in second line setting. So, in summary, in guidelines, if the patient is coming HER2 positive, Cleopatra regimen is still the standard of treatment. Then TDM1, and then many different lines of the combination of HER2 blockade could be used depending on availability, affordability, or the patient's preference or toxicity profile. If the patients are recurred early or unfit chemotherapy regimen, TDM1 is the first early can be used. Then this HER2 blockade could be used. In summary, pertuzumab, trastuzumab, taxane is the standard of care treatment for first-line HER2 positive metastatic breast cancer. TDM1 is the first ADC which demonstrates the efficacy in terms of PFS and also overall survival. Because of that, the TDM1 is the standard of care treatment for patients with HER2 positive second-line metastatic breast cancer. Efficacy, real world also data support that the efficacy is robust and the safety is similar to the previous randomized phase 3 study. PROS also they stands for TDM1 compared to other HER2 blockade or other TPC regimen. And also the exploratory and the retrospective analysis demonstrated that TDM has demonstrated efficacy, HER2 positive with CNS metastasis, especially so HER2 patients with CNS metastasis in second line, please consider TDM1. This is the last slide. So guideline recommend the first line and second line. First line, the pertuzumab Cleopatra regimen in first line, TDM1 in second line setting. Recent approvals of molecular such as tucatinib, TDXD is approved. In conclusion, the future outlook for HER2 positive metastasis is very promising and exciting. Why? Because we have a range of targeted therapies and combination treatment is actively ongoing. So, patients' characterizations of treatment selection likely to become increasingly important. Thank you for your attention. Carmen.